Thanks for those who've come bright and early, online and in person. This is our second annual Center for Youth Bipolar Disorder Research Symposium. We're delighted to have everybody here. Quick introduction to our team, and I wanted to start with a land acknowledgement. KMH is situated on lands that have been occupied by First Nations for millennia, lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of KMH appeared in the Colonial Records Office of the British Crown as the council grounds of the Mississaugas of the New Credit, as they were known at the time. Today, Toronto is covered by the Toronto Purchase Treaty Number 13 of 1805 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich the city. KMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis, and share the land and protect it for future generations. So before our first keynote, we're very fortunate today to have presenters from a number of different cities across Canada. We have guests from London, England, from Copenhagen, Halifax, Ottawa, and Pittsburgh, and we're thrilled to have them with us today. And I'm now pleased to introduce our Vice President of Research, Dr. Aristotle Voineskos, who is also Director of the Campbell Family Mental Health Research Institute, and also the Principal Investigator of the Toronto Adolescent and Youth Cohort Study, which is a large transdiagnostic cohort study with imaging and genetics that CYBD is part of, and we're very happy to have him here this morning to open us off.
Thanks, Ben. Hi, everyone, in person, online. I'll keep it brief. As Ben said, this is the second one. It feels like the last one wasn't that long ago. I remember it well. And CYBD is growing, which is fantastic. And what I think is especially exciting is not just the scope of research across the spectrum, from more biomarker-oriented research out to clinical trials and really innovative target engagement work, I think that you're all leading, but also I think the interest and the flexibility to consider children and youth across diagnoses and how CYBD can contribute to that work, which I think is particularly central to KMH's mission as we take care of some of the most challenging cases, not just in the city, but in the province. But today is a day about research and discovery, which is my very favorite topic, which should be a surprise. So I'm just super excited for all of you and for continued growth in the future. And I know Rudolf, and he's going to give a great presentation next. And I think what you'll hear a little bit about, although I haven't even asked him what he's going to talk about, so I hope he's going to talk about his Forbo study, at least partly, and some of the ways I think mental illness manifests in children and youth across disorders, from the point of view of heritability, but also in terms of symptom expression. So thanks for having me, and congratulations to you all for all your successes, and wishing you a great day.
Thanks very much, Aristotle. So it's now a pleasure to introduce our first keynote lecturer of the day, Dr. Rudolf Uher, Canada Research Chair in Early Intervention in Psychiatry from Dalhousie University. Dr. Uher is a psychiatrist and Canada Research Chair, as I mentioned. He completed his PhD in neuroscience at Charles University, psychiatry residency at the Maudsley, and a fellowship in genetics at the Institute of Psychiatry in London. Dr. Uher is testing early interventions to prevent mental illness and to develop personalized treatments for depression. He leads the Forbo studies you heard about from Dr. Voineskos a moment ago, Families Overcoming Risks and Building Opportunities for Well-Being, and that also the Treatment Interrupt Depression Early trial, TIDE, as well as a data science platform through the CanBind network. So involved in a number of different projects, and in terms of his connection with CYBD, I think the shared collaboration has come through mutual collaboration with our colleagues in Pittsburgh, and we're really looking forward to hearing your comments. Rudolf, thank you.
Well, thank you, Ben, for inviting me. Thanks for the kind introductions. And I'm very happy to be here and to see you all. It's also aware there's a number of more people attending online. So thanks for joining us today for the World Bipolar Day. And I will be talking about early identification of risk. And I'll try to make it as much focused on bipolar disorder as possible, although I'm aware that many people in this room know more about bipolar disorder and have done actually a lot of what I'll be trying to convey. So bear with me, I'll try to bring it together. It is about using all sources of information, so family history, genetics, and developmental manifestations of psychopathology when predicting and identifying risk. My disclosures, I have no commercial disclosures. The work I'll be presented has been funded by competitive grants from official granting institutions and by charitable funding. I will show the list of them in the end. In terms of outline, I'll try to look at bipolar disorder in developmental context and also in the context of other types of psychopathology. I will talk about prevention and prediction and the various components we have to help us identify risk, and starting with family history, genetics, and then going through psychopathology and biomarkers. I'll try to review the work on person-level identification as the next step towards actually moving from prediction to prevention. When talking about bipolar disorder, I find it hard to do it without the more common sister major depressive disorder. Couple of reasons for it is most bipolar disorders start as depression, start with depressive manifestations. And many of the young people we working with have not been old enough to reach the end diagnosis and confirm what the end diagnosis will be. So I say the diagnosis of major depressive disorder is always provisional. It can change to bipolar disorder at any time. Studies that followed people from first onset of major depressive disorder for long enough to tell suggest that this may be as high as 1 in 4. And given how common major depressive disorder is, and that half of it actually remains a single episode, it's quite a substantial proportion of the recurrent outcomes that turn bipolar. Given how impactful bipolar disorders and major depressive disorder are across the lifetime, over a very long time, they typically onset in teens, early adulthood, and affect people for decades. It's very important to think about what we can do as early as possible, ideally prevent the onset. And how to get to it, what do we know about prevention? The prevention is all kinds of things, and it starts with universal things we can do for every child, typically based in school or around maternity even. Can we change something to move the curve of risk for the whole population? And then we move towards selective prevention, that we select a subpopulation. So for example, children growing up in deprived neighborhood or children of affected parents would also be selective. And the third group is indicated prevention where we choose individuals who already manifest some earlier symptoms or presentations that suggest that they may be at higher risk. And it's a type of prevention that resembles more clinical work because we have symptoms to work with, although they are at that point sub-threshold or lower level symptoms. So how do these work? For bipolar disorder, we don't really have much. We have tested tests of family-focused therapy, and we have tests of cognitive behavioral therapy, mostly delivered in a group format. And we don't have a proof that any of these interventions actually reduces the number of onsets. That's not to play down their importance. They generally have other positive outcomes. They reduce symptoms. They are seen as valuable by the families. The studies may not have been large enough or lasted for long enough to actually see the effect of onsets. But we don't have evidence that early intervention can prevent onset of bipolar disorder at this point. So I moved to depression, and for depression, we have much more. We have all types. We have the universal and the selective and indicated that often actually happen together, and then we refer to them as targeted intervention. So for example, interventions tested in children of affected parents, but who also have symptoms. So kind of both selection and indicated elements in place. And what we have seen through a meta-analysis of all the studies is that the more targeted the preventions are, the more beneficial they are. And this is quite a different story. For example, in addictions and related health problems, we have the opposite story, and the weight is on universal prevention. But when it comes to depression, anxiety-related mental health symptoms, the targeted prevention seems to be more effective, and the effects seem to be longer lasting. There's even some evidence that the children at highest risk may actually have some negative effects from the universal interventions that may be targeted at population that perhaps faces much less challenges because they may feel singled out, or and they may feel like it's inappropriate, it doesn't apply to them. And that really brings me to the need to predict, to the need to foresee risk so that we can target interventions effectively. And other reasons for predicting who is at risk has been put, perhaps we can minimize avoidable risks. Some exposures are modifiable. There's a lot of interest from families for monitoring, so that the kind of seeing something happening is not just on the parent alone, but the targeted prevention and possibly treatment happening as early as possible in case of onset are probably the biggest drivers here. So I'll talk for the rest of my time about predicting who may develop bipolar disorder and related disorders, especially major depression. And I'll use several sources of data, starting of course with literature. It's systematic reviewing of literature is becoming a more and more important part of what we do. The growth in evidence is exponential. We in the process now of repeating data searches that we did roughly 10 years ago, and we're getting not just twice, we're getting 3-4 times more relevant eligible articles. So these are in process, but we see over 300 publications on the risk to offspring of affected parents, and over 200 papers showing prediction from early antecedents to onsets of major mood disorders in prospective studies. So a huge amount of data there that we need to keep summarizing almost in real time. My second source of data is the Forbo cohort, so thanks for both Aristotle and Ben for mentioning it. So this is a kind of home cohort built entirely in Nova Scotia. So it gives us a freedom what we want or need to collect, and we also have more intimate knowledge of the participants, which helps us to do more there. So at this point, it's 620 young people, of whom approximately 130 are offspring of parents with bipolar disorder. There's a larger number of offspring of parents with depression, smaller number of offspring of parents with schizophrenia, and also just over 200 what we call controls, but they are matched in where they live and where they go to school. So actually our controls are relatively higher risk in terms of socioeconomic circumstances than would be a general average population. And these just over 600 young people, they enter the study at different ages. They can be anywhere between 6-year-old and 19-year-olds when they're entering. And then we invite them for follow-ups every year. And up to date, we have completed 3,200 of these follow-ups, each time asking about what happened in the last year and repeating diagnostic interviews. So be talking about 600 kids, but we're talking about over 3,000 years of lives in the development of these kids. And because they enter the cohort at different time points, it's what we call accelerated cohort, which means, kids who enter still as children, let's say 8-year-olds, they tell us about how is the transition from childhood to early adolescent going and what's happening then. And the kids who enter in their early teens, we follow them through the adolescent, and those in late teens, we follow them into early adulthood. And the within-person continuity and between-person differences help us to form a picture about a longer developmental period over a shorter amount of time. We've already seen 86 new onsets, which is quite hard to see. So 86 of these young people, children often, who we saw first without a major diagnosis of mood or psychotic disorders, have developed one. The majority of cases, it was major depressive disorder, and but some of them it involves bipolar and psychosis. And the single highest risk group are actually the offspring of parents with bipolar disorder. If you look down the dark red numbers, they are per 1,000 of follow-ups, so they are comparable across the columns. So the 44 per 1,000 is the incidence rate among offspring. So that's less than 1%, but it's per year. So cumulatively, it becomes quite a high risk. So it's 4% per year. I've been fortunate to also get access to a much larger collection of young people being followed up over time, and several of you in the room have contributed some of these data. So this is a consortium of groups around the world, and it involves 8 cohorts from 6 countries where we followed young people prospectively with repeated diagnostic interviews, and the majority, all of them involve some young people at high family risk, offspring of affected parents. So this really allowed us to bring together larger numbers to answer more questions, perhaps at the cost of having some unavoidable differences between the cohorts in how they are assessed or how often they are assessed. And the primary push towards this was to be able to test molecular genetic predictors. We knew we needed larger numbers there. So I'll talk about it later. Across all these cohorts, the age at onset, the time when it's most likely to see a new onset of the first major mood disorder. So this is major depressive or bipolar 2 or bipolar 1. It does not involve, in this case, the minor depression or bipolar NOS. It peaks in the high-risk offspring, in the offspring of affected parents, around age 16 to 17. And you see that it's quite a sharp peak, actually. It's really at that time in the mid to late adolescence, we see very, very high number of onsets, first onsets. Then in the blue line, it is the comparison offspring of unaffected parents. And you'll see that the blue line will be peaking later. And this is consistent with the literature. It's not just that offspring of affected parents are more likely to develop a major form of mental illness, but they are also more likely to develop it earlier. I like to look at what else is happening in the development at the time. And in this picture, the thin red line is my attempt to draw the development of human capacity, intellectual abilities, what the humans can do with a rapid spurt in childhood, and then another very rapid growth in adolescence. And it's probably not a coincidence that the peak risk for onset of major mental disorders coincides with when the human ability is just about to reach its peak. There's something about the complexity of the intellectual brain functions that needs to develop that probably makes us vulnerable, or that brings the brain to the stage when the major forms of illness manifest. And by major forms, that's depression, bipolar disorder, psychosis. And for most people, that's not where it starts. Many, at least actually the vast majority of people who develop bipolar disorder or other major disorders in late adolescence have had other diagnosable or otherwise manifest problems earlier, starting with childhood temperament, early motor development, then impulsivity, oppositional defiant disorder, ADHD, irritability, anxiety, right? All of these earlier onset. And I'll look at how valuable these may be in predicting and identifying risk early. But first I turn to family history. Perhaps the most established risk factor for major forms of mental illness. This is based on a meta-analysis that we published looking at offspring of parents with depression, bipolar disorder, and schizophrenia. So the right middle column, that's our offspring of who have a parent affected with bipolar disorder. And you can see that the risk of bipolar disorder is significantly elevated against the controls. So in this case, the rate in controls was 2%, the rate in offspring of affected parents, 10%. So quite significant fivefold elevation of risk for bipolar disorder. But in addition to that, the risk of major depressive disorder is also elevated compared to controls, and the risk of psychosis is also elevated, including schizophrenia against the controls. Not so many fold, but when you add these up, the cumulative risk of an offspring of affected parents having serious illness is quite high. In this case, around 30%. And we are in the process of updating the meta-analysis, and the indications are that the next number will be even slightly higher, but roughly consistent with this. Interestingly, these are now data from Sweden, so this whole country data that depend on treatment seeking. So we only have registered kind of hospital or health system-based diagnoses here, but it shows a few things. Major depression is the first registered diagnosis for most people who end up being diagnosed with major mood or psychotic disorders, and transitions are common. And when they look at the loading in each family of similar diagnoses in relatives, so they count not just parents, but also second, third degree relative, weighting the scores to have like familial risk score for each type of disorder. These family risk scores are strongly associated with the final disorder. So an initial presentation of major depressive disorder in someone who has multiple relatives with bipolar disorder is quite likely to turn bipolar. And same for psychosis. So the big numbers in Sweden, they allow pretty nice patterns, but mind you, it's not the full picture, because one of the elements of this registry research is that typically patients only get registered one diagnosis at a time. And the choice is often like clinical decision making, and it's quite different from what we get when we do comprehensive assessments of all diagnoses. I'll turn to genetics next. Genetics is not the only reason why mental illness runs in families. Environment is shared within families as well, and parents are a huge part of our environment. That's why family is such a powerful predictor. But genetics has many advantages, including that we have it at birth or even before birth. We can have the entire genome measured. And the backbone of genetics nowadays are genome-wide association studies. So here's the latest one for bipolar disorder, published a couple of years ago by Neve Mullins and colleagues, based on over 40,000 cases of bipolar disorder compared to a vast number of controls. It identified 64 places in the genome, genes if you want, associated with the risk of bipolar disorder, but many, many more weakly associated. The plot on the left, for those who are not familiar, it's called Manhattan plot because we get some of the tall towers, but essentially it's a plot of several million p-values, several, each place in the genome, each variant in the genome being tested in a single test is more common in people with bipolar disorder than in controls. And because we're testing a few millions, the control for multiple testing requires p-values with many zeros, so the y-axis is on a logarithmic scales, and it's only the tall tower that we can declare as definitely associated. But a lot in the middle range also contributes to the prediction, and that's why we often use the genetic information in the form of what we call polygenic scores. And such a score sums risk across typically tens of thousands of variants that are strongly but also moderately to weakly associated, and that gives us currently the best tool to use genetic information. It's also nice to look at the genetics of bipolar disorder in context. Like, this is one of my favorite single graphics view of human genetics, and bipolar disorder is the last column from the left, or the last row from the bottom. And few things to show. The lines going to the right show the heritability, and you can see that bipolar disorder is one of the most heritable human conditions. Then the pie charts in the table, they show the degree of agreement between genetics for a number of traits, not just diseases, but also personality traits and other events in human life. Things like educational attainment or number of sexual partners are also highly genetically contributed. And when we look at what the disposition to bipolar disorder corresponds or correlates with, the strongest correlation is made with major depression. So no surprises here. There's some with schizophrenia as well. But otherwise, for example, there's an overlap between the genetics of bipolar disorder and the genetics of risk-taking that we don't necessarily see with major depression, but we do see with ADHD, for example. There is no overlap between bipolar disorder and educational achievement. For example, with ADHD, you would see negative correlation. With bipolar, we don't. So it gives you a shape of how the genetic vulnerability to bipolar disorder looks and comes around. This is work I'm very, very excited about and very grateful for the opportunity to do in collaboration with some of the people here, and namely the Pittsburgh bipolar Offspring study by us, where we could answer the question whether polygenic scores not just predict bipolar disorder, we know they do, but whether they actually add to family history in predicting bipolar disorder. And what we've seen is they do both. They can partly replace family history because they differentiate it of people with or without affected parents. But in addition, they predict which of these offspring develop major mood disorders over and above the family history alone. So one of the first demonstrations that a genetic test may actually add useful information to what we already know. The gradation in the graph is from the lowest scores in offspring of healthy parents who do not develop mood disorders, then offspring of parents with bipolar disorder who do not develop mood disorders, then offspring of unaffected parents who did develop mood disorders, and then of course the highest scores in affected offspring of affected parents. So kind of as expected and pretty strong relationship, especially pleased with it given that we only had around 400 after quality control here. So genetics works even with moderate sized samples. Now, this is moving into the larger cohort. So here it's nearly 2,000 young people followed up over time. And here we look transdiagnostically, both in terms of outcome, any major mood or psychotic disorder, but also in terms of the breadth of polygenic predictors. And we got a confirmation and a surprise here. The confirmation is that all the polygenic scores for bipolar disorder, schizophrenia, depression, they were linked to the family history, and they overlap with the family history in predicting who develops onsets. But the surprise was that the strongest predictor of who develops onsets of major depressive, bipolar, or psychotic disorders was a polygene for neuroticism. So in some ways, something that's at the very mild end of psychopathology, but comes from a huge population sample, is turning useful to predicting some of the most severe forms of illness. And it adds very substantially because it does not overlap that much with family history. The two lines in each is the one uncorrected and corrected for family history, and the neuroticism prediction changes very little. It's almost as strong that when we pull together these polygenic scores, the prediction is almost as strong as knowing family history. So getting more signal here, and the genetic signal is getting stronger as the discovery samples are growing. I'll turn next to antecedents, and I use this term in agreement with Danny Pine about early manifestations. Typical of psychopathology also involves cognition. There are conditions of individuals. So we don't include environment here that precede and predict onsets. Typically, they can precede predict onsets longer in advance, so not just the immediate prodrome. And they often are transdiagnostic. Based on the literature review, we identified 4 that have the transdiagnostic capability, and they typically are distinct in type from the eventual disorder. And that perhaps differentiates this from the at-risk state that may be more diagnostic specific and closer in time. We were looking for things that may help us predict from further away in development, and their affective lability, the tendency to mood changes out of context or disproportionate to any environmental impulses, anxiety, psychotic-like experiences or psychotic symptoms outside the context of psychotic illness, relatively common in childhood, and basic symptoms, also unusual experiences, often involving the temporary loss of ability that people see as irritating. And we looked at them. Now this is the 4-bow cohort, and first we compared people who had any one of these antecedents on earlier assessments and those who had none. And the incidence rates were quite different. The raw incidence rates were about 8-fold higher in people with antecedents. The antecedents also becoming more prominent with age and other risk factors. So when we correct it, we still have hazard ratio of over 4 times increased risk in young people with antecedents. So fairly strong, robust prediction that may be amenable to selecting people for early interventions. Of the 86 onsets we've seen in 4-bow, 80 were in young people where we saw at least one antecedent. Only 6 were unforeseen. But given the high risk nature of the study, actually we have many more young people with antecedents than without. So that what brings you to the 4 to 8-fold difference. Now, which of the antecedents predict? And the answer is anxiety is by far the strongest. I take this still with a pinch of salt because most of our onsets at this point are depressive. And interestingly, we did not include subthreshold depressive symptoms in the antecedents. We are quite keen to go in the heterotypic way, but anxiety even trumps subthreshold depressive symptoms when you test them side by side. And it certainly shows a stronger effect that affective lability, psychotic-like experiences, basic symptoms. Having said that, each one of the 4 independently predicts, each one adds to the prediction. And when we look at the more severe outcomes at people with psychotic and bipolar disorders, like our 9 onsets of bipolar disorders, almost all of them have multiple antecedents. So there's definitely value in looking at across domains. It's demonstrated in this relatively smooth increase. This is the risk per year, given the number of antecedents, 0 to 4. in the previous assessments. And you can see that it goes up quite steeply up to around 20% per year. This is annual risk. So that's really comparable to what's seen in the prodromal work. And each additional antecedent increases the hazards about 1.4-fold. This is the 4 antecedents compared to anxiety alone. So although anxiety is strongest, the combination of 3 or 4 antecedents gives us an even stronger indication of risk of onset and perhaps indication for early intervention. Antecedents can also be diagnoses, and sometimes the advantage of looking at diagnoses is that we have them in larger samples collected in a very similar way. So here is an example where we looked at prior diagnoses of anxiety and ADHD in the whole Danish population and birth cohort. So the advantage of looking at 2 million people observed over 30 plus years, right? And the selection, anxiety is a kind of internalizing disorder, ADHD as more externalizing neurodevelopmental disorder, two of quite a different kind, yet they co-occur. And the finding was that having either anxiety or ADHD diagnosed in childhood increased the risk of bipolar disorder about 10-fold. And having both of them diagnosed in childhood increased it around 30-fold. I mean, the folds are very high numbers here, and that's what happens within a registry database where we only see the treated cases. So the low base rate lead or allow the high ratio values, but certainly confirmation that both types of diagnoses are strong predictors of outcomes also works for psychosis, by the way, with very, very similar ratios. Now, in our collection of prospective data, we may have the ability to bring these antecedents together with the family history. So this is our consortium data brought together, and the risk by family history of mostly major mood disorder, a very clear separation there. So what happens if we add childhood diagnoses here? And if we add anxiety, so these are the 4 combinations of anxiety and in offspring of parents with major mood disorder, highest risk of them developing major mood disorders themselves. Young people who do not have anxiety and do not have parents affected with major mood disorders have the lowest risk. And then the 2 combinations of having one but not the other are in between. And in this case, the presence of anxiety actually is stronger, brings more risk than the presence of family history without anxiety disorder. So it just demonstrates the strength of how much childhood anxiety predicts. This is the same picture for childhood ADHD, and it's kind of similar, except the 2 middle lines are flipped. So here, ADHD also contributes, but the family history alone is a stronger predictor than ADHD alone. So you can say that ADHD contributes to the prediction of bipolar disorder and major mental illness onsets, but relatively specifically within the context of family history. Unlike anxiety, who does so even outside context of family history. So this is work in progress. We're also keen to add to it. I won't go into details with biomarkers. I'll just say that there's been a lot of focus on brain imaging, and we're getting all the issues with limited sample sizes and selection effects there. My experience is that of a cohort where we can collect clinical information from 95+%, we struggle to get 2/3 into the scanner. So that there's costs associated to that type of research, even given the excitement of having brain data. So we investing a fair bit into data that are relatively scalable, and some of this involves speech analysis, especially focusing on the acoustic on the sound of speech. That's perhaps more hardwired and harder to change than what we say. and also at some molecular biomarkers of inflammation, glucose metabolism. Actigraphy, I think also has a huge scalability potential, and looking at the combination of all the modalities of brain function recordings, of course, has massive potential. There are other features, like this is an example of body mass index, something we looked at because of the known comorbidity of obesity with major mental disorders later in life. We are kind of interested where this starts, and what we found is that especially in girls, there's this kind of separation or crossover even around the onset of puberty, from which point on the high risk girls develop bigger bodies compared to their lower family risk counterparts. So, at this point, they don't have a major mood disorder. They're not getting treatments that could contribute. So it's kind of interesting thoughts about what's happening in their bodies at this time, and how much of this is behavior and actually earlier milder symptoms, and how much of this is something pretty hardwired physiological. To finish, I'll turn into kind of bringing it all together. We have multiple types of predictors that we know are associated with outcomes, such as the family history, genetics, early diagnoses, antecedents, possibly biomarkers. How well can we predict for one given individual? Will they develop a disorder or not without an intervention? And this is the domain of risk calculators. There have been several published, a couple in family high-risk studies, and at least one in general population, seen in a systematic review of these. And just a glimpse through it, I think one of the, or possibly the most promising, is the authors are here and can tell you more about it. Comes from the bias study from Pittsburgh. So family high risk study, the prediction is especially among offspring of affected parents. And the predictors include the age at onset in the affected parent, younger age at onset associated with greater risk, as well as a number of subthreshold symptoms, both manic and depressive, as well as anxiety and affective lability. The distribution of scores here relative to the likelihood of outcome is very, very encouraging, suggesting a good calibration of the model in the sample where it's been developed in bias. The next challenge is to see how well it generalizes to other samples. Here's another model from another family high-risk study. This is a Canadian study, and here there was the built-in replication in a Swiss study, but even combined, they're actually smaller than bias. So I think it suffers from lowish numbers, but they have a very long-term follow-up. The type of predictors, it's very similar predictors that they picked for the model. It shows consistency. The graph on the right shows you the strength or accuracy of prediction that varies by age. And the accuracy in the discovery cohort is the red line with the red shaded confidence interval. And you can see that it's gradually trending upwards. So the prediction is not great. On average, it's actually lower than in bias. But the older the young people get, the more accurate the prediction becomes. And the gray shaded area, the black line, that's the replication attempt in the Swiss cohort. Now, this is 128 young people. I don't think it's large enough to really give it a proper test. On average, it's lower. The prediction is less accurate, which suggests that perhaps a degree of overfitting in the development sample, but the trend upwards is there as well. So the closer we get to the late teens, early 20s, the more accurate we are able to predict. And this is something I've seen across all publications on this. Here is a a very good piece of work from Brazil, from the Pelotas cohort. So this is a general population sample, a birth cohort of almost 4,000 young people. And they tested and developed predictors from assessments at birth at age 11, 15, and 18, and then measured the final outcome at age 22. And what you see here is very low predictive values at all the ages until 15, and then suddenly a very good prediction from age 18 to age 22. There's some major questions because age 18 was the first time they actually did diagnostic interviews, so they had much more information. But the way they collected data, I didn't see an assurance that some of the cases actually did not already have an onset by age 18, in which case that would inflate the prediction quite dramatically. But in other ways, the pattern of stronger prediction at later ages, but relatively poor prediction and in the early adolescence is consistent with the family high risk studies. The type of predictors overlap quite significantly across the family high risk efforts, less so with the general population cohort, but overall there's consistency, and none of these include biomarkers, and none of these at this point include genetic tests. So all of these are kind of questionnaire and interview-based clinical predictors so far. Subthreshold depressive and hypomanic symptoms are very consistent, especially in the family high risk cohort. Anxiety stands out as featuring strongly in all three of the risk calculators, and I would say this is strong agreement with what we see in Forbo. I probably mentioned all these overall features here. The next step really is to show whether or how well any of these models can predict in a completely independent new samples, ideally across sites or across countries, and that remains to be demonstrated. The attempted replications have shown substantially worse performance, but they were also never planned as replications, so there were differences in measurement and types of assessment, not just in where the participants came from. So that remains an open area to work in. So I'll summarize here. I think bipolar disorder onset is very substantially predictable at group level statistically. We have a number of very established confirmed predictors now. Family history, molecular genetics, early psychopathology, antecedent diagnoses, they all contribute non-redundant information. The individual level prediction that will be meaningful for early interventions, it's a harder task. And especially when it comes to predicting early enough and predicting across sites and types of recruitment and data collection. There's so far divide between the kind of most of what I've seen that was specific to bipolar disorder, and other work that I have not shown is looking transdiagnostically, and Forbo is an example there, and that is to be weighted towards a more common diagnosis like major depression. And so far there's this relatively mild, weak evidence of the benefit of early interventions, but there's certainly strong suggestions of feasibility, including in our own work, where we don't have the prevention result, but we do see that the families do take on the interventions and do complete them. In terms of next steps, I think there's a real need to bring in the objective markers into the prediction models. I think they actually have a chance to be more reproducible across sites and countries than whatever is dependent on what people tell us. I think there's need to integrate the diagnosis-specific and transdiagnostic, because I think the diagnosis-specific prediction efforts work well in short term, and we've seen it in the age trend in the prediction. When you're close to the actual onset, the subthreshold symptom paradigm works quite well. But when you try to predict further ahead, like years ahead of time, the predictions are becoming less specific. And that may also be needed because that will give us the opportunity to actually change functioning, to intervene before kids miss graduations or completing milestones with their peers. And finally, so far all the work has been about predicting who is at highest risk and who needs a intervention. And so far the results about intervention efficacy have been quite mixed. That it's a mixture of enthusiasm and families who believe this changed their lives completely, but overall the average results are not so strong. And I wonder if we need to think actually about personalizing the selection of intervention. Who needs what kind of intervention? Not just who needs a intervention. But this is probably several steps away to just be able to do it. So I'll stop here. I have many organizations and many people to thank. On the left are the funders, so Canada Researchers Program and Canadian Institutes of Health Research have made the biggest contribution to making these things possible. Genome Atlantic provided the primary funding that enabled us to bring together the consortium, and there's a number of additional funders, including the Sutton Family Fund that provided huge flexibility in the work we do. And what I presented is a work of at least 40 people, who many of them are here, and thank you, and looking forward to do more together.
Thanks so much, Rudolf. Really great overview of the literature. The findings are, I think, compelling and push us towards understanding how this can make a difference for individuals. And I thought that the integration of interventions is a really elegant aspect of your work. So thank you for that. We have a few minutes for questions, and then what we'll do is, I think if there's not time for all of the questions that people have, we can have people email us at youth.bipolar@camh.ca, and we'll do our best to connect with the presenters and get those answers back to you. But any questions in the room? Dr. Singh.
Well, this is excellent. I really love the articulation of so much data from so many years. What do you think about the relation between neuroticism and anxiety? And I'm curious to understand, if we think very broadly about phenotypes that are antecedents, you kind of describe this story. You can see the overlap between neuroticism and anxiety present phenomenologically. So I'm curious about that.
That's a very good question. I was looking into it since we saw that strong prediction there from the genetic score, right? So what goes into neuroticism? And actually, it's a bit of everything, but a huge part of it is anxiety. So like the self-awareness, the self-consciousness, that's core part of social anxiety is one of the questions that loads the strongest on the neuroticism score. Tendency to worry about future is there as well. But additionally, there is affective lability involved in neuroticism, tendency to proneness to major emotional reactions. And there are also things that we don't tend to ask about so much in psychopathology assessments. There's like the tendency to boredom, easily bored or not feel engaged. There's also irritability. So I think one of the advantages of neuroticism is that it captures a broader range of related psychopathology that's perhaps more generic. It generalizes more to males, females, because like anxiety is very strong female weighted, especially anxiety other than OCD, whereas the impulsivity, boredom, and affective lability and irritability. So especially boredom, irritability, they tap into a more male manifestation. And it seems like they got it right. They do hang together well genetically. and that may be why it contributes. But the other side of it is completely methodological, and that's the fact that we got neuroticism genetics on the entire UK biobank, which is like 80,000 people drawn as a single sample. That's the bulk of the neuroticism GWAS, and the numbers make it a powerful predictor. So I like the concept, but I don't want to read too much into it unless we have parity. Like, for example, ADHD polygene predicts, and it's based on 20,000 people, like fraction of what we have for neuroticism. So it may be that ADHD is really, really good phenotype. So,
Yeah, no, I think about just the approach avoidance balance too in mania. And so thinking very much around like, how does mania then fully manifest with this, ready, impulsive, reward engagement, and then avoidance and the juxtaposition of those.
that's why we were interested to bring the internalizing, externalizing together.
A question from online. Can you comment on what your thoughts are on autism spectrum and where that fits in?
Wow. So this is a hard one, and it's harder for me because I trained with Michael Rutter, and it's I'm finding it very hard to accept the kind of broadening view of autism spectrum that's happening now. I tend to see autism as the core symptoms that are based in reciprocal communication. And I believe a lot of the apparent overlap between mood and autism that we think now, it actually is driven by the soft edges of the spectrum, by this kind of unusual and hard to classify mix of neurodevelopmental and affective psychopathology, which I think it's a group that actually is significant, both in terms of numbers and in terms of degree of impairment, but I don't think it's benefiting in being chunked with the core autism. And I'll stop here because I'm not I don't have more complete experience with it.
I think we have time for one more question.
Yes, Georgina, thank you for this. That's an excellent question. I'm very interested in sleep problems, and we have it as one of the, like, I listed the 4 definite antecedents, and then we have a couple of like experimental, and one of them is sleep. And I didn't show it or didn't focus on it for a couple of reasons. One is we see more discrepancies between samples and studies on whether and how sleep predicts mood disorders onset. And the other one, we have more problems with measurement. Like, sleep is typically poorly remembered and poorly reported. And what we see is that the prediction tends to be driven by self-report of sleep and then not confirmed in objective measurement. And this has been now shown in several studies. So sleep disorders diagnosed by interview tend to predict major mood disorder onset. We don't have consistency in like sleep disorders being assessed the same way across the cohorts, right? Because just seeing how much the rates vary, it was part of the reason we focus perhaps on anxiety and ADHD more. We have more consistent assessment. We always see prediction from questionnaires. In our own data, we have questionnaires and we have actigraphy, and we see that in the same people, the questionnaires predict, the actigraphy does not. And actually, even some of the signals are contradictory. So in the self-report, it's the poor sleep that tends to predict mood disorders problems. And in actigraphy, the association is actually, if anything, with longer sleep. So, not necessarily what I expected. But then I showed you that correlation of all human traits genetically And interestingly, and in the Neef-Mullins study, in the GWAS, one of the genetic correlations of bipolar disorder was with longer sleep duration. So it's an area I'm very interested in. I don't feel like I have the final answer, and it's an excellent question to bring in. Thank you.
Thank you very much, Rudolf.
Thanks, everyone. Happy to talk.
So again, there are some great questions online. Since we don't know your emails, please do email them into youth.bipolar@camh.ca. It's now a pleasure to introduce a longstanding colleague and friend, Dr. Manpreet Singh, who's an associate professor of psychiatry and behavioral sciences at Stanford. Dr. Singh is leads a research program aimed to accelerate understanding and treatment in youth with or at high risk for developing a persistent or chronic mood disorder. Her research examines mechanisms underlying the development and treatment of mood disorders as adaptation to stress. She applies cutting-edge research strategies to pursue novel therapeutic targets like innovations in trial design, directly modulating the brain using transcranial magnetic stimulation, and examining responses to real-time neurofeedback. She's also investigating the efficacy and safety of existing pharmacotherapies and psychotherapies for youth with and at risk for bipolar disorder, such as antidepressants, family-focused therapy, and mindfulness meditation, with the goal of reducing mood symptoms and family stress. Manpreet, over to you.
Terrific. Well, thanks so much for, while we get set up, I just want to thank Dr. Goldstein, the Center for Youth Bipolar Disorder, and the whole team. It's just lovely to be back in Canada. I am Canadian. I grew up in Canada, so you'll see some of my Canadian sensibilities shine through in my presentation. And I will hope also and thank Rudolf for really nicely setting up the why we care about youth at risk for bipolar disorder, so I don't have to cover that piece, and focus mostly on using neurobiological assessments and to inform our treatment strategies and approaches. So we'll kind of talk a little bit about the integration of some of these biological tools with a focus on neuroimaging into our clinical high-risk setting. So with that, I'll go ahead and also share my disclosures of potential conflicts of interest. I do collaborate and advise for a number of pharmaceutical companies who are innovating on next generation therapeutics for a variety of different conditions. They're the ones that are developing and advancing these treatments, and it behooves us in academia to collaborate with them and inform them and give them our perspectives. So, so I do share this because I will be talking about some innovative strategies that are off-label in my presentation today. So we will talk about the current standards of care in terms of diagnosis and treatment of bipolar disorder and comorbidities. We'll talk about clinical challenges that make it hard for kids to engage in treatment response and early intervention and prevention, because that's what we want them to do, because we think that early engagement will lead to more, will lead to fewer episodes and lifetime morbidities. And then we'll try to talk about just the current armamentarium of evidence-based strategies, how we're applying them in at-risk youth, and the innovation landscape to really think about how we can cultivate hope with our patients, especially those who are struggling with multiple treatment failures. And of course, Nelson Mandela poises this well for us. There can be no keener revelation of a society's soul than the way in which it treats its children. And with increasing gun violence in globally, and aggression and all sorts of challenges we're facing, these are things that we have now a responsibility to continue to lean into. So this is also a slide that I'm not going to spend too much time on because I'm preaching to the choir. You all know that bipolar disorder starts young. Most adults with bipolar disorder describe their onsets in childhood or adolescence. And, you know, it shouldn't surprise you that Rudolf was saying that your accuracy of prediction becomes greater at older ages. You know, the secular trend towards younger ages is observable. We can debate the prevalence of it, but we really ought to, you know, we generally believe that the earlier onset really reflects still an adolescent a time frame for frank or full mania. But what are the antecedents of that, and how do we understand who will go on to develop classic bipolar 1 disorder versus something else? Bipolar disorder we know is chronic, and it's persistent. It continues into adulthood if it starts in young childhood or adolescence, and earlier age of onset does predict continuity. It's increasingly being recognized. Maybe it's because we're doing a better job of understanding it. Before, we didn't believe that kids could be depressed, and now we believe that kids can be depressed. Why don't we believe that kids could have bipolar disorder? So these are things that are, again, secular trends that are noticeable. Are there biological explanations for that, like earlier pubertal onset in youth, as a kind of a parallel process that might be leading to earlier onsets of psychopathology in general? It's complicated. Bipolar disorder runs with multiple other co-occurring conditions, whether they're the antecedents that started first, like anxiety or ADHD, that continue into progression, into more complex psychopathology. I'll recommend that you watch the movie Concussion. It's the story of chronic traumatic encephalopathy. For me, that movie explained where the intersection of multiple psychopathologies really occurs, where you don't see any frank evidence of anything until post-mortem brain pathology, where really, if you have recurrent bonks to your head due to sports injuries, you know, you can have numerous evolutions of numerous psychopathologies all layered together and have very significant consequences. And in my view, bipolar disorder, schizophrenia, serious mental illnesses that last a lifetime are a representation of that kind of complexity. Symptoms can be managed. We have some great evidence-based strategies. When they work great, but most of the time, about a third of kids get better, about a third of kids get worse, and about a third of kids stay about the same. How can we increase our probability of success here? And that's why I've been really focused on figuring out ways to develop better strategies to intervene. And then here's my Canadian sensibility: prevention. An ounce of prevention can go a long way, and yet we don't really invest in that nearly in the ways that we could. Because if we can predict it, perhaps we can prevent it, and perhaps with more measurement and tools to be able to help effectively predict who is going to go on to develop psychiatric conditions that last a lifetime, maybe we'll be in a better shape to be able to prevent its progression, and maybe even imagine a cure for bipolar disorder. How about that? So just to also provide you guys with some context for why I'm fussy about depression in addition to bipolar disorder. Rudolf mentioned very eloquently that depression is the definitive precursor, and it's the most common initial presentation of bipolar disorder, and leaves many people flummoxed, because if you don't evaluate someone with depression for mania every single time they present with some mood symptoms, you're likely to miss a bipolar diagnosis. So that's been one teaching campaign that I've been on, particularly to our allied health professionals and physician extenders, because, you know, in a very, very brief clinical encounter, sometimes it can be daunting and overwhelming to actually ask questions about mania when it seems completely far afield. But in my view, any patient who presents with any mood symptoms ought to be comprehensively assessed for all of the continuum of mood symptoms that could present. And this again alludes to my question to Rudolf earlier about approach avoidance and the continuum between anxiety and externalizing, internalizing, externalizing, and the really important tuning that seems to be occurring between these paradoxical, if you will, extremes. It's also true that in clinical trials, particularly in pediatric clinical trials, in depression, we've had a number of clinical trial failures. The kids who are, there's only now, by the way, only US FDA approved treatments for depression. There are only two, fluoxetine and escitalopram. And why haven't we had more approvals and more innovation in pediatric depression, unipolar depression, is because of this very interesting phenomenon of the placebo response that we see very commonly in pediatric clinical trials. And the additional benefit of psychotherapies is observed, especially in suicidal teens, but a lot of these evidence-based therapies are not accessible. I know Dr. Tina Goldstein is going to be talking after me about her efforts to disseminate, and I'm very proud to be part of her efforts to ensure that patients across the country have access to some of these very important evidence-based therapies using now telehealth strategies. Mood disorders are, we know, as I said, clinically heterogeneous. The long-term effects of untreated mood symptoms and treatment are either unknown or hotly debated. Okay, so leave well enough alone, doctors saying, wait till something actually happens. And then when it happens, maybe it's too late. So how do we know what to do and what to begin with? And this is where I think the psychotherapeutic interventions become really key in pediatric populations, at least as a first line intervention. And then kids also present with these really complicated juxtaposition of mood symptoms. Mixed states are very common in youth, and they're understudied. We don't really understand the phenomenon very well, the concept of rapid cycling, or is it actually cycling between mood states, or the actual juxtaposition of these mood states? These things can coexist. And they often do in terms of how they're reported by children, but how do we treat them? So let me talk a little bit about the placebo response again here, because I mentioned that it is a common phenomenon observed in depression trials. It's a common phenomenon observed in depression clinical trials in youth. And it sort of alludes to the fact that we have a number of different strategies that contribute to the treatment effect. You know, you have a regression to the mean. There's lots of reasons why people just naturally get better, because that just happens with time. There's some specific effect of the treatment. The specific effect that is what most of clinical trialists are looking for. They don't want anything else to be a factor, and they have to control for a variety of different variables to ensure that those confounders aren't why a particular treatment works. And then you've got these non-specific effects, the effects of talking to a friendly person, someone who's going to give you some support. Pediatricians will often be very surprised and disarmed by when I tell them that they're doing supportive psychotherapy in their 15-minute general well-child check with children, because they are doing a lot of psychoeducation. They're providing a very nurturing and supportive orientation, patient-centric orientation, and that has some effect in that, whether or not we try to be really stoic and not convey that is very difficult, because we're human. So we have to contribute to that, and we have to understand its contributions in our clinical trials. So I think that we have to do a better job of really elucidating what this placebo response is, so that we can do a better job of signal detection and knowing what treatments are working and why, but also to be able to harness and leverage the really sensible ways that we can provide primary intervention or prevention just by being a friendly face. Last night when I was doing CrossFit, I found somebody so interesting. I was like, this is so Canadian, but it's exactly why I love coming back to Canada. Everybody got a fist bump afterwards by someone in the group, and I think that those kinds of supportive inclinations are really important. But it's also important to understand where the patient is in terms of their desire to change, their desire to get better. And so how do we understand their expectancies, their social factors that might contribute, whether they trust you or not, whether it's because you are of a particular race or gender. Are there other contextual factors that contribute to successful treatment? And how do we optimize that? So this preamble, I think, in the context of youth at risk for bipolar disorder is important because all of these factors need to end up becoming part of our trial design efforts for these youth. So the treatment approach that we have generally gone with involve a multimodal approach, psychotherapy first, and then sequentially followed by pharmacological interventions if they're indicated or psychotherapy doesn't work. Sometimes it's a goodness of fit issue and other areas of exploration, but iterative challenge and re-challenge in addition to exploring potential psychopharmacological interventions is helpful with the ultimate goal of remission, but really it takes a lot of trial and error to get there. And this is why all of the researchers here in this room are so focused steadfastly, not just on prediction, but on precision, on figuring out ways to help people match the right treatment as soon as possible, because what happens when you have multiple trials and errors, you lose trust and you become more pessimistic that things are going to work. And this has an impact on treatment effect. So we need 3 key breakthroughs to prevent bipolar disorder from lasting a lifetime. And this is a prevention framework that I've tried to write about and describe, in part because I think it provides a framework that everyone can get behind. Primary prevention is the biomarker detection strategy. It helps us understand even before a patient develops any symptoms, what are the factors that contribute to response. Or potential intervention before symptoms even begin. We know that there's a family history of bipolar disorder. Are the things that we can do to really optimize the chances of a child in a family that might experience a lot of chaos, have all of the skills and tools they need cognitively to lead their best lives. For secondary prevention, many of those kids will go on to develop some subthreshold symptoms. They may or may not represent mania symptoms, but very commonly present with depression, anxiety, ADHD. So here we are with our secondary intervention strategies before we reach full bipolar disorder. And these preemptive interventions are really for those folks who are already symptomatic or in the early symptomatic stages of risk. And then tertiary prevention is really the place where our comprehensive tertiary care centers live. This is where we need to innovate on better treatments that for people living with bipolar disorder that predict and track outcomes. Very commonly, we do an assessment of a patient with bipolar disorder. The previous longitudinal studies in adults with bipolar disorder, on which we rest so many of our inferences about the onset of bipolar disorder, was called the STEP BD study. And that study was very careful and meticulous about measuring and tracking outcomes of every single patient that walked in the door with bipolar disorder, because it gave people a sense of what are the clinical issues. From that study, we learned that anxiety was a comorbidity that was really difficult to treat and had an impact on prognosis. We learned a number of things from that study about how to iterate towards better treatments. We learned that compliance, adherence to medication and treatment is very difficult, especially in the early phases. But early lithium exposure can set people up for better long-term outcomes. So how do we make sure that we give patients access to those treatments? So these are, again, setting up a little bit about some of the work that we've been doing at Stanford to really target the individuals that are suffering from these conditions and make sure that innovation is happening in those individuals as well. Because if, for example, there's a strong placebo response for depression, imagine who is going to go, especially in kids, who's going to go and do clinical trials in those kids? Who's going to do clinical trials in bipolar disorders if it's so complex? We have to make an effort to really empower and help industry and other folks who are innovating to develop better treatments, because those treatments take a long time to reach our patients. So this is an orientation, I think, that we're ripe as academics and colleagues in the community to really partner around. We understand that there's homeostatic factors that calibrate the difference between someone who's going to go on to develop bipolar disorder or some form of some mood episode versus someone who might be resilient. We've seen tons of kids, offspring of bipolar parents, who don't ever go on to develop anything. In fact, lead very sustained, successful lives. I know many of them personally, and it's very interesting. What is it about their brains that make it possible for them to have successful adaptive outcomes versus those siblings or other families who don't experience that? So we've been using neuroscience tools to help us understand the natural ways the brain remodels towards adaptation, but also what are the potential insults to normal or typical brain development that might lead to an episode of mania or depression. And we understand too that treatment is part of that framework as well. So I'm going to go through some of the work that we've done in the primary, secondary, and tertiary prevention strategy approach in our program. We've tried to study children because we think that they can tell us clues, give us clues about how to prevent and potentially cure bipolar disorder. We understand that kids may not be mini adults, but the problem with saying that kids don't have bipolar disorder and therefore they're not capable of having this condition, or they're different, or the phenomenology is different, is that, you know, bipolar disorder is a lifelong disorder that very commonly starts in childhood or adolescence. So we have to understand its continuity and discontinuity, and what are the conditions that make that so, including a misdiagnosis. But these are factors that are influenced deeply by the fact that development is very variable and leads to different kinds of phenotypic expressions. It's why kids often present as diagnostic orphans. It's why they have multiple diagnoses before they get to some confluent underlying understanding of what exactly they're going to have for the rest of their lives. And it's why they're so fun to study, but so complicated to study. And we also understand that how they metabolize medications is potentially very different. So our strategies for normal psychopharmacological treatments is going to be different than it would be for use for adults. And so we start low, go slow when we give medication trials, and we're a little bit more cautious than we are in the adult world. I remember when aripiprazole first came out, people were dosing this medication at 10 milligrams to start with in kids. And so we saw tons of kids coming into our clinic with dystonias, and it's one of my first case reports in the Orange Journal, and it was quite remarkable that you could really see the potential problems of, you know, treating kids like mini adults. So those contexts, the developmental context, is important. The other thing I would say is that youth at risk for bipolar disorder really do actually show signs of neurobiological differences compared to non-familial or other psychiatric controls, and even before the onset of any symptoms. So I'm going to show you, again, why we use the model system of a family history. Because, you know, we all have our good days and bad days, and many of you have seen this picture of my children, you know, who are beautiful and wonderful to each other in some occasion, and then very quickly shift to aggressive behaviors, and those things are part of normal development. But what happens when these things become more like patterns? And when we did our first studies of offspring of bipolar parents, we actually focused on kids who didn't have any symptoms. They looked behaviorally just like any other kid on the street. The only difference was that they had a family history of bipolar disorder. And what we found was that their brain networks, their brain activation patterns, their connectivity patterns, they all were very different from the kids who didn't have a family history of bipolar disorder. And in fact, those neural correlates seem to actually also correlate with environmental stressors like family chaos. So the more chaotic the family environment in high-risk youth, the more disconnected their brain networks were. So these were early signs that maybe we should look into this phenomenon a little bit more deeply. We began to do more imaging in youth offspring of parents with bipolar disorder in healthy states, pre-symptomatic, again, never disordered, never had any psychiatric conditions. We then also recruited a group of youth with family history of depression to see if we could understand the differences between family history of depression versus family history of bipolar disorder. And lo and behold, the brain was very sensitive. Imaging was very sensitive to delineating whether somebody had depression or a family history of depression without any symptoms. And so being able to see these subtle differences in the brain is actually a confirmation that we can potentially use this tool pre-symptomatically to be able to look for neurobiological markers of disease evolution. Of course, we have to longitudinally follow these youth, but let me just show you another sort of, again, level of sophistication in terms of imaging, that we're now able to also use a number of different tools that help us understand the brain's organization, the networks that are organized in certain populations over others, and lo and behold, even our hunch about the organization of networks in the brain are continuing to persistently demonstrate that youth at risk for bipolar disorder, even before the onset of symptoms, have different brain organizational patterns compared to youth without any psychiatric family history. When they develop symptoms, they begin to show neural patterns that are consistent with depression phenotypes. So in this comparison, what you see is actually an analysis we're currently conducting in youth with either depression or anxiety and a family history of bipolar disorder, bipolar 1 disorder, and compared to healthy controls. And in the graph theory analysis that we conducted, we found weaker connectivity patterns, mainly located in the default mode network. This is a region of the brain that's really important for self-reference, for self-referential thought, self-esteem. It's also associated with depressive rumination. And so this network is showing deficits in connectivity compared to healthy controls. The visual network is also looking like it is overly engaged in high-risk youth compared to healthy controls. And this was during this particular analysis is of a task that was presenting traumatic pictures through the international affective IAPS pictures, and those pictures were shown to these kids with some distractors to perform a continuous performance task with these distractors, these emotional distractors. And in the process of conducting this task in the functional MRI, you see these segregations of abnormal patterns of functional connectomes. But let's go back to the youth who have a risk of family history, bipolar disorder, but don't have any symptoms. And here, what I wanted to share is the story that my graduate student now, who's got a PhD, Dr. Uher, showed over the last few years in conjunction with an evaluation of a study that we did independently years ago in first episode mania, where we characterized the reward processing of youth with first episode mania and showed thalamic disconnectivity patterns and decreased activation while youth were anticipating rewards and losses, money rewards and losses in the scanner. I actually talked about this last year at CAMH, so I won't belabor that, but here I want to just demonstrate that Uher demonstrated a continuous signature of the same kinds of patterns of activation, deactivation, and disconnectivities in the thalamus during monetary reward processing in the scanner, very similar to what we saw in youth with first episode mania. So here you have kids who have a healthy status, but have a family history of bipolar disorder showing very similar patterns in the brain. So these coherent brain and behavior associations can then be followed over time. And so in a risk and resilience study, we've now followed 150 youth with or at risk for bipolar disorder, depression, and healthy controls, 50 in each cell, and followed them over 3 or 4 years. This is the follow-up after 3 or 4 years. And what we found was that youth that had decreased connectivity, particularly during emotion processing, and then I'll show you intrinsic networks in the next few slides, show more pure problems and increased risk for a mood disorder or an anxiety disorder at follow-up. So again, you see this sequential from health towards internalizing mood disorder. We didn't see evidence that these youth developed externalizing disorders like ADHD, but internalizing seemed to be more represented in this sample. Weaker, again, connectivity to an area of the brain that regulates emotion and also processes faces and facial expressions, the fusiform gyrus. This connectivity pattern was not only associated with youth with a family history of bipolar disorder compared to youth with a family history of depression, all at a stage of health, but that connectivity pattern, again, just like we saw before with chaotic family environments, correlated with higher family rigidity scores. In contrast, kids who had a family history of bipolar disorder also showed some patterns of resilience. We saw kids who actually showed normative follow-up behaviors, showing strengthened ventrolateral prefrontal cortex connectivity to executive control networks that correlated with better functioning. And in this particular follow-up, longitudinal follow-up, we found that increased baseline functional connectivity at rest and during emotion processing characterized youth who went on to become really yet resilient, whereas decreased connectivity was associated with those who went on to develop some sort of mood internalizing disorder. Also curious was that the kids who were more resilient were more prosocial. They were able to make and keep friends for sustained periods of time. So on our follow-ups, when we evaluate these youth, we're not just asking them, you know, are you experiencing symptoms, but how are you functioning in your day-to-day lives? How is the evolution of your functioning going? Because we know that functioning matters to these youth as well. And they are thriving in that regard. And so we thought to ourselves, well, that's interesting. Is there a way for us to maybe help these kids make and keep friends? We can do that. That's something that's in our wheelhouse. This is what we do when we do psychotherapy with kids, right? So we did some pilot work with David Miklowitz. He was at the time at University of Colorado, where we did a 3-site study, now 3-site study with UCLA, Colorado, and Stanford to evaluate family-focused therapy intervention. And in our initial pilot data, we saw a signal that if you give any sort of psychotherapeutic intervention, whether it was just psychoeducation, a friendly face, or family-focused therapy, it actually improved that same prefrontal activation that's necessary to be able to make and keep friends and to effectively communicate and problem solve. So this was one of our initial signals that maybe psychotherapy not only has an effect on helping kids make and keep friends and behavioral manifestations of clinical improvement, but also that it has some effect on the brain. So we wondered if we could actually do this in a more systematic way with a randomized controlled trial. And so what we did is we randomized kids who have a family history of bipolar disorder, who are already symptomatic, so they need treatment. And the first treatment we want to give them is psychotherapy. Some of them were already also on medications, but we balanced the groups. And some of the kids got enhanced care, which was psychoeducation alone. And the other kids got these additional skills, which I think are essentially pro-social skills. They're skills to cultivate our capacity to make and sustain relationships with each other. Communication skills, knowing how to give positive feedback, knowing how to give negative feedback, problem-solving skills. How do you solve problems, not just by yourselves as individuals, but in the context of a family environment collaboratively? And so what we call the 3 components of psychoeducation, communication, and problem-solving skills together is family-focused therapy. So some kids got the whole shebang, and then some kids got the enhanced care. And what we found was a prevention story. What we found was that in the acute phase of the treatment, from baseline to 16 weeks, there were really no differences between the kids from a symptomatic improvement perspective, from the kids who got just a friendly face and some psychoeducation versus the full skill development plus the psychoeducation. But when you follow these kids 3 to 4 to 5 years out, you begin to see some separation between the two groups, where the kids who got the family-focused therapy actually showed some reductions in depression relapse compared to the kids who got psychoeducation alone. So this family-focused therapy is really showing some signs that it can be preventative. It could prevent a depression relapse. We need to do more to better understand if we can now truly prevent bipolar disorder. We didn't see that same effect on mania prevention, but none of these kids went on to develop mania either. So family-focused therapy, when we did the initial evaluation of the symptom scores, we were bummed that we didn't see separation on symptoms, but guess what we saw in the brain? We saw some really interesting separation in the brain where the treatment groups didn't separate on symptoms. We saw that the kids who got family-focused therapy actually showed an increase in connectivity between the ventrolateral prefrontal cortex, a really important region for emotion processing, and the area of the brain that is part of the anterior component of the default mode network. So this area that we know is deficient in connectivity that I mentioned to you before is now showing some treatment-associated increases in connectivity with all of the controls for all of the other spurious variables put into place. And also very interesting that the connectivity improvement also correlated with improvement in depressive symptomatology. These kids, in addition to getting a resting state scan, which is what the data I described in the previous slide, got an emotion processing scan and a problem solving processing scan, because we wanted to see, again, ecologically, if what we were training these kids on was actually transferring in the brain. And lo and behold, we saw both increases in dorsolateral prefrontal cortex activation during emotion processing and medial prefrontal cortex activation during problem solving. So again, a shoring up of areas of the brain that are really important for these executive functions. So we're developing a working model of how these different mediators, both intersectional mediators between the brain and behavior and other psychosocial contexts, that help us understand what is the happy space, the happy recipe for us to be able to really place these kids at the best possible outcome. And so and published that in Current Neuropsychopharmacology earlier this year. So in the final phases, I'd like to talk to you a little bit about how we should treat depressed or anxious youth who may be at risk for bipolar disorder, who don't benefit from psychotherapy. What do you do next? And the sequence of events, typically, regardless of whether you have a psychiatric family history of bipolar disorder, is to go ahead and try a trial of medications. But we've now also observed that youth, in particularly youth with a family history of bipolar disorder, are at increased risk for having a treatment emergent side effect from an antidepressant. The secular trends also show that kids are more likely in general, and Jeff Strawn demonstrated this in this nomogram. You can see that the rate of adverse events is higher at younger ages. That makes sense to us because now we understand kids are not mini adults, that their brains are developing and may be more sensitive to side effects. So how do we understand this particular problem, this confluence of age effect, but also family history of bipolar effect? And we've collaborated with University of Cincinnati to do a randomized controlled trial for youth who present with depression and anxiety, but have a family history of bipolar disorder, randomized them to escitalopram or placebo. All of the kids in this intervention got family-focused therapy. So that's going to be your baseline treatment effect. It's going to be the effect of family-focused therapy, which we already know changes the brain, which we already know has an impact on potentially improving symptoms. But ethically, we felt we could not give kids who are symptomatic with depression and anxiety, moderate to severe levels of that, nothing. It just didn't seem right. So the base is, as you will, is family-focused therapy. Okay, so and based on preliminary data, we saw kids who had a family history of bipolar disorder who had an adverse reaction, had amygdala hyperreactivity, smaller volumes in the amygdala. So there was a clear biological confluence of data that suggests we should really study this group of kids and see if we can understand better when they get side effects and how they get them. They were randomized. We did baseline scans on them. We did scans at 4 weeks. And then we also did a scan if they experienced any side effects that required stopping the medication. So discontinuation of an antidepressant was constituted a hyperarousal event. So we're beginning to now analyze these data that we've been collecting over the last several years. And lo and behold, if you look at the yellow and blue lines here, you see in our initial analyses, these are preliminary still, but there's no separation across the 16 weeks between Lexapro and placebo. Why do you suppose that is? We've got kids who are all getting family-focused therapy. They're all getting better. You can see that the trends are towards symptom improvement, and improved functioning is what you see at the bottom, right? But escitalopram did not perform better than placebo for these youth. Okay, this was not an efficacy study. This was a safety study. We didn't care to demonstrate that Lexapro works or not. That was a secondary goal. But if you look in the brain, what we saw and are beginning to see are these really interesting changes in the brain that correspond to signatures for vulnerabilities towards side effects. So early changes in connectivity between the amygdala and the ventrolateral prefrontal cortex, neural mediator of developing a treatment effect versus a side effect of treatment. Remember I said to you before, the brain has the capacity to delineate risk from disorder. This is now evidence that it can actually delineate between treatment and side effect, which is something that's very difficult for us clinically as well. Another interesting preliminary finding is that early changes in connectivity, again, when we seeded the amygdala and the right ventrolateral, when we seeded the amygdala, we found resting state connectivity to the ventrolateral prefrontal cortex that met statistical significance as a mediator of the treatment effect on the change in depression severity. So we do also see a pattern in the brain that helps us understand treatment effect. We did pharmacogenomics in these youth and see some potential value in using pharmacogenomics to help us understand which kids are maybe more susceptible to side effects. And there was a very clear signal, mostly in the serotonin transporter gene. So again, preliminary, but we're looking to see whether or not this holds in our follow-up analyses, but that kids who had a specific allelic frequency for the serotonin transporter gene were more likely to have higher levels of self-injury. And so you can imagine that if you can detect this on pharmacogenomic screening, perhaps a family history of bipolar disorder would be an indication for one to do a cheek swab to help guide pharmacological treatment. So in my last few minutes, what I'd like to talk to you about is just the business of tertiary prevention and how we get to testing, developmentally informed, personalized, and novel treatments for youth with and at risk for bipolar disorder. I just showed you the first set of the data from the antidepressant study for youth at risk for bipolar disorder. It's the first of its kind to really understand how this, in a randomized control fashion, how we can actually treat these youth. We have some smaller trials and actually, unfortunately, mixed studies on youth at risk for bipolar disorder on what works and what doesn't work. And so this is really going to be hopefully a step in the right direction for us to be able to personalize who should get medication and at what dose and how we should pace it. These remain unanswered questions. And you can see, again, even in our comprehensive treatment approach, we still have some work to do to delineate treatment effects. I mentioned this before, the US FDA approved landscape for depression is pretty limited. And for bipolar disorder, it's better. But we still don't have anything for bipolar 2 disorder in kids. We don't have anything, we have very few for bipolar 1 depression. but that's increasing. And we don't really have a lot of information about what we should do in the long term because most of these youth need continuous treatment. Last year, Cynthia Hsu, who I think was in the audience. Hey, Cynthia, good to see you. She presented this poster at World Bipolar Day last year. So I'm just going to give a shout out once again on this analysis. This was a post hoc analysis on lurazidone's randomized controlled trial in kids with bipolar 1 depression. And the goal that Cynthia was seeking to do in this particular analysis is really to look at networks of symptoms. When you look at the depression severity scale and the mania rating severity scale, there are some symptoms that are represented in both. What are the bridge symptoms between depression and mania? What are those mixed states? What are the potential areas of common concern that present in these kids so frequently? And can we understand whether our existing treatments are helping those symptoms? And so in this post hoc analysis, she found that the bridge symptoms of sleep dysfunction, either a decreased need for sleep or insomnia, and irritability very commonly came up in the analyses and not only predicted acute treatment response, but also predicted a remission down the line. So longer term treatment results also showed separation. Showed improvement over time. And so this is helpful because for the kids that are really struggling with sleep problems and irritability, maybe lorazepam would be a good, more personalized treatment strategy. But if we go into symptom networks just based on the presence or absence of categorical symptoms, sometimes it becomes difficult to hang our hat on that. So we need to do more to understand which medications are going to work and for which symptoms. You know that there are a number of other treatments out there for bipolar disorder beyond what's already FDA approved, and that cariprazine is also in the potential, going to be part of the potential in terms of across the bipolar spectrum, bipolar 1, mixed, manic, and depression. The other cool thing that's coming in the horizon are completely different mechanisms of action. So we're now looking into potentially giving youth, well, hopefully down the line, but in adults anyway, in adults with schizophrenia, they're doing trials in treatment mechanisms that don't even involve dopamine 2 blockade. So we can circumvent all of the need for all of these additional anti-diabetic medications that we're supplementing for SGAs potentially, and to be able to give kids down the line the ability to get these novel treatment strategies would be great. They will come with their own side effects, of course. We have muscarinic agonism and antagonism. We've got trace amine associated receptor agonism. Learn about these mechanisms. I think they're going to be very interesting, but again, will come with their own set of potential challenges. So the problem, though, is that it's going to take 10 years before we get any of these treatments to kids. And there's a variety of reasons for that. Probably good that we don't give these kids experimental therapeutics right away, that we're careful and we test them and we make sure that they work in adults before they get to kids. There are other strategies that are trying to be evaluated to accelerate innovation in kids. There's a guidance now globally by the same harmonization group, the International Consortium on Harmonization, to bring approach to regulating novel treatments together. They came out with a guidance on pediatric extrapolation. And the idea is to say, can we find ways to accelerate innovations that have been proven in adults into kids? And so by fast tracking those applications, making sure that safety is evaluated in kids, but not necessarily having to spend a decade or more doing these independent trials in kids. So that's potentially hopeful. But there's also a number of other things we can do to potentially address these challenges. And I would really urge you to consider, as you innovate, how do we iterate on more safe, maybe complementary treatments, integrate digital health technologies, investigate interventions that actually improve kids' adherence through whether it is the social connection or otherwise, and really increase the diversity of our trials and our research so that it's truly representative. And then, of course, there's a number of non-pharmacological strategies on the horizon that are very exciting. We're actually doing theta burst stimulation in adults with bipolar disorder now at Stanford. My hope is that we can demonstrate feasibility to do this in adolescents with depression. We have had 2 or 3 cases that we've run, and then the pandemic happened. So we're working our way back to being able to try to demonstrate the feasibility of doing targeted neurostimulation using brain imaging pre and post. And that's the recently approved FDA strategy called SAINT, directed by Nolan Williams. From the perspective of digital therapeutics, we know that computerized CBT works, and it works really well. But there are a number of kids who don't benefit from it. So who are those kids? How can we better understand that, and how well or effective our digital therapeutic strategies are in the long term? And then we can't let kids who have bipolar disorder, especially first episode mania, fall off the cliff when they go to college. So one of the other things that I've been working a lot on, especially in the pandemic, because this became very acute, is a lot of college students, very smart college students who get into Stanford and other very accomplished schools, experience their first episode mania in college and don't have access to services or readily available comprehensive care. So we started this Fair Start program. It was philanthropically supported to really bring in college students who are experiencing their first episode of mania and give them time-limited psychopharmacological interventions, get them going. And I have a number of youth who are doing very well thanks to that early intervention. Patient centricity is really an important goal in my view as well. Kids don't just want to have like no more depression or mania symptoms. They want to be better. They want to function better. So we've done a number of analyses in our high risk studies to really understand how do the correlates or how do the trajectories of functional outcome look compared to symptomatic outcome. And those curves look very different. So I think it's important for us to track those patient-centric outcomes as well, so that we can focus on more evidence generation with diversity and patient centricity in mind. Children may not be many adults. Bipolar disorder can be evaluated reliably as well as risk with development in mind. And there's lots of treatments out there, but you have to be mindful that there might be actually neurobiological dysfunctions that predate any symptom development. And that's an important reason for us to be intervening early. And that there are there's also a need for us to do some combination effectiveness therapies and maintenance trials to understand the longer term benefits of treatment. I put up a picture of my sister who has Down syndrome and congenital heart disease, and she inspires me. And she reminds me that we are resilient. It's important for us to know what our intrinsic adaptive mechanisms are, as well as those that might make us vulnerable. So with that, I'll conclude, and I'd love to hear your questions. Thank you very much.
Thanks so much, Dr. Singh. Great presentation. Took us from a Mandela quote to muscarinic receptors and everything in the middle. So I think we have time for 2 succinct questions if folks have them. Anyone in the room? And
I was so interested in whatever you guys do. I have a doctorate degree in developmental psychology, and I did my research about attachment styles and depression. And I'm quite interested with the bipolar disorder. And I was interested today because I've never read something has to do with youth, bipolar with youth, because it's very recent. And I'm interested to know more about the treatments. And usually when we talk about young adults, people directly would ask for the help of the psychiatrist to give them to go back to the average medication with, along with the psychotherapy. While with children, as I noticed while you're speaking, that you would prefer the family focus the therapy first, and then figure out what kind of medication you're going to give. So I would love to hear more.
Yeah. Yes, so I really appreciate the question about stimulants and whether or not, we're seeing, a need to potentially try to address certain behaviors with psychostimulants versus behavioral interventions, and speaking specifically about the ADHD potential prodrome. And we do know that ADHD is a prodrome for bipolar disorder, and not treating it could have significant consequences. Behavioral interventions, unfortunately, don't have the same effect sizes as stimulants do. In fact, I would say out of all of the tools that we have pharmacologically, if you look at all of the effect sizes pulled together, stimulants are whopping effect sizes, like close to 1 or above. And so nothing comes close to that. And certainly, I think that a combination of medication plus behavioral therapies increases the overall treatment effect, as we can imagine combination therapies do. So I don't want to disregard that, but I've had the experience as a psychiatrist of trying to treat a kid who is very inattentive with behavioral interventions alone. Really tried 6 months, and he was still hitting everybody under the sun. And he was 5 years old, and it felt very wrong to prescribe him a stimulant. And then once he finally failed behavioral therapy, I did the stimulant, and the kid completely about faced and became very functional in his classroom and in learning. So we can't ignore the fact that we have to engage some pharmacological interventions. It's interesting, there are some groups that are much more sensitive to the potential adverse role of psychostimulants in the brain, especially in kids with a family history of bipolar disorder. If you talk to Melissa Del Bello, she will say to you that psychostimulants are just as problematic as antidepressants. We have not seen that in other settings. We've seen that psychostimulants are actually very helpful. And so treating the underlying ADHD might actually prevent the incipient progression towards mania. We don't know that either. But that's a good empirical question to ask and for us to study. So that could be potentially the makings of another clinical trial.
Thank you so much. Thanks, Dr. Singh. Okay, welcome back, everybody. It is a real honor to welcome back our friend and colleague, Dr. Tina Goldstein from the University of Pittsburgh. So Dr. Goldstein's clinical and research interests focus on understanding the etiology and psychosocial treatment for youth with and at risk for mood disorders and suicide. Her research program is supported by grant funding from federal and private foundations, and she is the author of over 150 manuscripts and book chapters. Her contributions to the field have been recognized by numerous awards, including the Clerman Young Investigator Award from the Depression and Bipolar Support Alliance, and the Presidential Early Career Award for Scientists and Engineers. And if you're lucky, Dr. Goldstein will tell you how she thought that the call from President Obama's office was a prank, but I won't get into that. I should also flag that Dr. Goldstein has spearheaded, and we're going to hear about this, dialectical behavior therapy research in the field. You would think that this has been something a lot of people have focused on. It's actually not the case. So we've been very fortunate that she's worked with us in a dissemination and implementation study and enabled our group here at the Center for Youth Bipolar Disorder to be fully trained up by the best of the best and be able to, proudly offer the high quality treatment that those patients deserve. So Dr. Goldstein.
Thank you so much. I'm just so honored to be here today. Those were incredible talks this morning. And I think it really is a wonderful way to celebrate World Bipolar Day together, which I know sounds a little bit ironic to be celebrating a disease. And yet I feel like the reason that we're here is to bring hope and build hope. And that's exactly what I felt and experienced during the talks this morning. And I hope that this brings more of that to you, because I feel like the people in this room and online and in our kind of larger community of clinical scientists, that we will get to a point where we will be able to have a cure for bipolar disorder. And in the interim, learning more about how we can better help and support individuals living with this disorder and their families and friends. So, let me see if I can move my slides forward. There we go. So I just want to start with my disclosures. As Dr. Goldstein mentioned, I do receive grant funding from a number of different agencies, some of which you're going to hear about today, the work being supported by the National Institute of Mental Health and the American Foundation for Suicide Prevention. In addition, I am an employee of the University of Pittsburgh, and I do receive funding from the Pittsburgh Foundation as well. All right. So in order to give some frame for the treatment research I'm going to be talking about today, I want to give some background to how I got to specifically dialectical behavior therapy, or DBT. So we've long known that individuals with bipolar disorder are at extraordinarily high risk for suicidal behavior. Among adults with bipolar disorder, between 1/4 and 1/2 will engage in a suicide attempt at least once in their lifetimes. And between 8 and 10% will die by suicide. So that's 1 in 10 adults with bipolar disorder will die by suicide. We also know that individuals with bipolar disorder engage in more highly fatal suicide attempts than individuals with any other psychiatric disorders. And so while we know that individuals with major depression, schizophrenia, and substance use disorders are also at high risk for suicidal behavior, individuals with bipolar disorder are more likely to die from their suicide attempts than those with other psychiatric disorders. So this is truly a lethal disorder for many of our patients. We know from some adult retrospective studies that those adults who report that their illness onset early in life are at even greater risk for suicidal behavior. Here are some early data from the 90s from Pete Lewinson's group that I always like to come back to, because what they really highlight is the elevated risk for suicidal ideation and behavior among young people with bipolar spectrum disorders, shown here in red, as compared to young people with major depression, shown here in blue. Whereas about half of youth with major depression exhibit suicidal ideation, nearly 3/4 with bipolar disorder have suicidal ideation. Similarly, about 1/4 of youth with major depression report a suicide attempt, whereas almost 1/2 of youth with bipolar disorder report a suicide attempt. Furthermore, a really interesting study from one of my mentors, David Brent at the University of Pittsburgh, showed in a psychological autopsy study of youth who had died by suicide that of all diagnoses, bipolar disorder was most overrepresented by 13 times among those youth who died by suicide. It also happens to be the most costly psychiatric disorder to manage in youth, bipolar disorder more so than any other mood disorder or Axis 1 psychiatric condition. And that's primarily driven by ER visits for overdoses and inpatient hospitalizations for safety. And so we can really think about suicidal behavior in this group of youth with bipolar disorder as costly, lethal, and also something that's potentially modifiable. And that's really what's led me to this body of work. So I've been incredibly fortunate to work with Dr. Bermacher and many of the other folks in this room today on the course and outcome of bipolar youth study. It's a large multi-site longitudinal study of over 400 youth diagnosed with bipolar spectrum disorders. And in this study, we've been assessing these youth every 9 months over up to 20 years at this point. So most of the young people who we met on average at age 12 are now in their 20s and even early 30s. And so years ago, when I first came to the University of Pittsburgh, I asked Dr. Bermacher, can we look in the Kobe sample at rates of suicide attempt? And so first what we did was look at study intake. On average, the youth were about 12 years old when we met them. What we found was that on average at age 12, 1/3 of the sample, these are all youth with bipolar spectrum disorder, had already reported at least 1 lifetime suicide attempt at that point. And remember from data you saw earlier, the onset of major mood disorders, and same for suicidal behavior, on average is not until later adolescence. So these youth haven't even passed through the highest risk period for suicidal behavior yet. What you can see here is that this represents the 1/3 of youth who engaged in a suicidal behavior up until intake. And on average, there were about 15% who had very high lethality of their suicidal behaviors, meaning that there was every expectation that they would die from their attempt. And so then what we did was look over follow-up. So we had all of this longitudinal data in these young people with bipolar disorder. And so trying to better understand what are the patterns of suicidal behavior over time. What are we looking at here? So as you saw, about a third reported suicide attempt at intake. When we followed them over 5 years, we saw 20% attempted again over that 5-year period. And of those who attempted, nearly 40% attempted more than once over that 5-year period. So an exorbitant percentage of our youth with bipolar disorder are not only engaging in suicidal behavior, but re-attempting over time. And so in this longitudinal examination, what we did was try and really identify what are some of the near-term risk factors for suicidal behavior in this sample? Because we all know that young people with bipolar disorder are at high risk for suicidal behavior. That is all 446 youth in this sample. But it doesn't tell us anything about when are they at highest risk. And so what we did was look at the 8 weeks immediately preceding a suicidal behavior and compare those 8 weeks to all of the other 8 weeks over follow-up to try and better understand what was different about those 8 weeks as compared to the others. And we found some of the usual suspects that we also find in the adult literature, things like worse depression, worse substance use, not surprising to any of us. What was particularly surprising and very concerning is that actually in that 8 weeks, the youth were actually getting more psychosocial services. So they were actually getting more intensive outpatient programming, more partial hospitalization, even inpatient. And yet those suicidal behaviors still occurred. Now, of course, from these data, we can't tell how many suicidal behaviors we prevented, but nonetheless, that was a significant factor. So on the one hand, the good news is that people were recognizing that these youth were struggling, that they were at higher risk and they needed more services. So that's the good news. The bad news is that in many of these instances, we actually were not preventing the suicidal behavior. And as Dr. Goldstein mentioned earlier, the somewhat surprising and kind of baffling point and take-home point to me is that even to date, there is no psychosocial treatment that expressly focuses on suicidal behavior in individuals with bipolar disorder, and none for youth with bipolar disorder. And so that's how I got here, was recognizing this huge gap that we really need to be targeting suicidal behavior in our psychosocial interventions for young people with bipolar disorder. So I know we all in this room know that optimal treatment for early onset bipolar disorder and adults with bipolar disorder includes a combination of both medication and psychotherapy. And it's really important to me to highlight that there are several evidence-based psychosocial treatments for young people with bipolar disorder, which is really promising. The field has come such a far way in the last 20 years in terms of learning about which psychotherapies help for mood stability in particular, and psychosocial functioning in these young people, some of which you heard from Dr. Singh this morning, including family-focused therapy and cognitive behavioral therapy. And what you'll find is that these treatments and many others that you may know of in the literature, interpersonal social rhythm therapy, cognitive behavioral therapy, multifamily psychoeducational groups, they actually have much more in common than they have different. They all include psychoeducation about bipolar disorder, careful mood monitoring, teaching people really to understand their symptoms and track their symptoms over time, building skills, some of which you heard about again from Dr. Singh this morning, interpersonal skills, problem-solving skills, communication skills that we all know are critical for enhancing functioning. And then also relapse prevention. When you're monitoring your mood and you notice that you may be dipping or going up, what do you do? What do people around you do to help potentially head off a full episode before it occurs? So you might be asking yourself then, why do we need another treatment? We already have FFT, we already have CBT, we know that these are efficacious treatments. Well, part of what I know from studying suicide for many, many years is that the treatment of the mood disorder is necessary. There is no question. We need to treat bipolar disorder in order to help decrease suicide risk. However, it may not be sufficient to decrease suicide risk. And why do I say this? Well, first, the most suicidal individuals generally are excluded from almost every randomized controlled trial, both in bipolar disorder and even in adult studies not in bipolar disorder. And there are good reasons for that. We do tend to do, first, very tightly controlled studies. And it also gets to the idea of why probably not more people have done this before. We do tend to take care of some of the sickest young people. It can be scary to be working with such high-risk folks, and particularly in the context of psychotherapy treatment studies where we are carefully monitored. That being said, it's also incredibly rewarding. And as one of my mentors has very eloquently put it, the risk. Okay, code white is okay. Okay. There's also a risk of doing nothing. And as you saw in these early data I presented, the risk of doing nothing is that people are losing their lives to this illness. We also know that suicidality is also associated with other factors that predict poor treatment response. Dr. Singh was talking about, we know treatments work well for a proportion of people, but not for all people. And in fact, many of the same things that put someone at risk for suicide also put people at risk for non-response to medication treatments and other psychotherapies. And it turns out that mood and suicide risk are not always closely tracking together. And so in many studies, it is not the most depressed period where individuals with bipolar disorder will engage in suicidal behavior. Sometimes it's when they start to feel a little bit better and get more energy. Oftentimes it's when they're actually having mixed symptoms of both depression and hypomania or mania. And so in fact, by just focusing on the mood, we're actually missing the suicidality as its own treatment focus. So what do we actually know about psychotherapy and suicide risk in bipolar disorder? Well, the good news is we know that there are efficacious treatments for suicidal behavior in other diagnostic populations. Adults with borderline personality disorder, depression, even young people with major depression. We really don't know anything about efficacious psychotherapies to prevent suicidal behavior in bipolar disorder. I highlight the couple of studies that have been done so far, and all of these are very promising. However, none of them have been shown to be more efficacious than a control at decreasing suicidal ideation or suicide attempts. In general, they have very small sample sizes, so there's still a very far way to go. But it's always fascinating to me that for many of these studies, they don't even report on suicidal outcomes in this very high-risk sample. So a take-home message to anybody who's studying these populations, that this is such a critical outcome for us to be tracking over time. So this is how I was led to dialectical behavior therapy. So if you're not familiar with DBT, I'll give you the 1-minute primer. So it was originally developed to treat adult women with borderline personality disorder. And the reason I was so drawn to DBT specifically is that the adult literature had shown that DBT has a specific focus and is efficacious for decreasing suicidal behaviors in this high-risk sample. It also targets other common treatment targets that we see in young people with bipolar disorder. For example, emotion dysregulation, impulsivity, interpersonal difficulties. And so all of these data really came together to highlight that DBT may be a promising intervention for targeting suicidal behavior in this population. And to be clear, one of the reasons that it's been hypothesized that DBT is so effective at treating suicidal behavior is because of this treatment hierarchy that we adopt in DBT, where we are always putting at the top of our treatment hierarchy on any given session, any given day, any life-threatening behavior. So oftentimes before I came to DBT, we would start our sessions when I was working with young people with bipolar disorder, talking about mood, right? Assessing mood symptoms, sleep, all of the things that go along with mood. Totally critical in treating individuals with bipolar disorder. Now, when I'm doing DBT, that's absolutely part of our picture. No question, we know that mood and suicide risk are related. And we don't move on until we first address any life-threatening behavior. And so as Dr. Goldstein mentioned, we are hardly the first people to have this idea. There was nothing particularly novel about it. Here's this treatment that treats suicidal behavior in other populations. It has great promise in bipolar disorder, and no one's done this before. So a recent systematic review of studies of DBT in bipolar disorder identified 11 different studies. 2 of them have been conducted in youth. Those were by our group. The first was an open pilot study where we essentially established feasibility and acceptability. The second was a small randomized controlled trial where we did find improvements in DBT as compared to a standard of care psychotherapy that primarily included some of those evidence-based principles that you saw earlier. There also have been 9 studies in adults. 6 of these are randomized controlled trials, generally small pilot randomized controlled trials, and 3 pre-post studies. I think it's really critical to highlight, in general, all of these have small sample sizes. They do demonstrate feasibility and acceptability, so patients with bipolar disorder in general do engage with DBT well. They come back for the treatment, that's all good. But we really need to be studying longer term outcomes. We need larger studies. And interestingly, only 2 of these studies reported on suicide attempt outcomes, even though it seems that that's such a critical outcome to be attending to when we're looking at this particular treatment for this population. The other thing I want to highlight is that oftentimes folks talk about receiving DBT, and it turns out that DBT is actually quite an intensive intervention when delivered in its standard fashion. And so many times DBT-informed studies will be delivering DBT skills, which is a critical part of the model, but not the entire model. And there are some studies showing that skills alone are efficacious. However, most of these studies in bipolar disorder, and particularly those in adults, have been looking at either DBT skills only or modifications of DBT skills, which we call DBT-informed treatments. So I think it's just important to make that distinction as we're being kind of good consumers of the psychotherapy literature, and as we're thinking about the patients and participants that we're working with. Okay, so years ago, I said, why don't we try this out? And so what we did was we made some minor adaptations to an already existing adaptation of DBT for adolescents that has been studied very well now in 2 large randomized controlled trials for youth with mood disorders at risk for suicide. Again, in general, youth with bipolar disorder were excluded from those trials. So I've been fortunate to work with Alec Miller and Jill Rathus, who created that intervention. We made some adaptations that I'll talk about in a moment, specific for youth with bipolar disorder. We used all of the standard DBT treatment components in our study. So this includes skills group, individual therapy, coaching outside of session to help the skills generalize, and also a consultation team, because part of what we recognize is treating these high-risk youth can be very challenging, very stressful. And so recognizing that we need a team, we need a community to be able to support ourselves, to be able to support the patients we're working with. And so the adaptations we made specifically, we do a 1-year treatment protocol, in part because we recognize that bipolar disorder is a cyclical illness. And so we want to make sure that as we're working with these youth and their families, they have the opportunity to apply the skills that we're teaching them across mood states. And so that's part of the rationale for this 1-year intervention. In standard DBT, skills are delivered with multi-patient groups. And we determined that we wanted to deliver these treatments with family units. It's so critical. You heard this morning about the heritability of mood disorders in these families, both from a genetic and environmental perspective, the significant emotion dysregulation that occurs in these families, both because of the mood disorder and as a result of the mood disorders and other co-occurring conditions. And so we are teaching these DBT skills to the youth and their families, and sometimes their siblings, aunts and uncles, whoever wanted to come to the DBT skills. And really what we're doing is giving them a common language for thinking about problem solving, communication, and ensuring that these skills are generalizing. We alternate week to week between a family skills session where we're teaching the whole family skills and an individual session with the young person where we're really helping them to apply the skills to whatever problems they're encountering. And so here's the study design from our large randomized control trial that we recently completed. This was funded by the National Institute of Mental Health. So essentially what we did, we recruited youth with between the ages of 12 to 18, all diagnosed with bipolar spectrum disorders. We randomized them. Everybody got medication management using an algorithm from our fantastic child psychiatrists, some of whom are in the room, who managed the medications of these youth over time. In addition, half of the youth received DBT over 1 year, and the other half of the youth got what we call standard of care psychotherapy. So I am so fortunate to work in a fantastic multidisciplinary clinic where we have social workers who are trained in other evidence-based treatments for bipolar disorder, including family-focused therapy, cognitive behavioral therapy, interpersonal and social rhythm therapy. So those were the therapists who delivered the standard of care psychotherapy. So it's a high bar. And that was important to me because we know that those treatments are efficacious, right, for managing mood. We then followed the youth quarterly over 1 year. So here's the sample. You can see on average, the youth were 16 years of age when we met them. As we unfortunately find in many of our tightly controlled treatment trials, the people who seek these trials tend to be more female sex assigned at birth. On average, we had about 45% who identified as a sexual minority. Largely, the demographics of our sample reflect the demographics of the Pittsburgh area. All of this intervention was delivered in person and pre-pandemic. On average, about middle class, you can see a range of bipolar spectrum disorders, all diagnosed via semi-structured interview. On average, the youth had been ill for about 3 years. On average, they'd had about 2 or 3 other treatments before they were referred to our study. About 62% of them had a history of psychiatric hospitalization and a lifetime suicide attempt. I also really want to draw your attention to this line for meeting criteria for borderline personality disorder, or BPD, because so often when I give this talk, and maybe not in this group, but maybe, folks say, well, don't all these kids just have borderline personality disorder? And that's really what you're treating here. So we did a semi-structured interview, diagnostic interview, the gold standard for diagnosing borderline personality disorder, which indeed we know that borderline personality disorder can co-occur with bipolar disorder. And they're oftentimes also misdiagnosed in both directions. And so what we found was that about 8% of the sample also met full criteria for borderline personality disorder. So what did we find? So I was actually really excited by this first outcome. What we found was that DBT, as compared to our standard of care psychotherapy group, so DBT here is shown in blue, standard of care is shown in red, performed equally well in terms of percentage of time over follow-up with depression and mania or hypomania symptoms. And so what that tells us, remember our standard of care group was evidence-based psychotherapies for bipolar disorder that we know are efficacious for managing mood. And so DBT performs equally well, no differences between groups in terms of improving depression, mania, and hypomania. One of the core treatment targets in DBT, and another reason I was really drawn to this intervention, is because of emotion dysregulation. We know that emotion dysregulation also underlies pediatric bipolar disorder. It is a core feature, and you heard some more about affective lability, emotion dysregulation earlier this morning. And so what we found is that those youth who received DBT as compared to standard of care, even though their mood trajectories were almost identical, the youth who got DBT improved substantially more in terms of their improvement in emotion dysregulation. So this is a self-report of emotion dysregulation. And what you can see in this slide, we broke it out. And if you do a median split, it turns out that about half of the youth, and they're all elevated on emotion dysregulation, but some of them are even substantially more elevated. So that's this blue and red line at the very top. And when you take those folks out who struggle the most with emotion dysregulation, what you can see is this significant separation between the youth who improve substantially in blue with DBT in terms of their emotion dysregulation, and the youth in red who started out high and pretty much stayed high. And so what this is telling us is that DBT is engaging that treatment target of emotion dysregulation very effectively. So when I first saw this slide, I'm not going to lie, I was kind of disappointed, which is that there were no significant difference between groups in terms of number of suicide attempts or risk for suicide attempts over 1 year. Okay, and so they weren't significant differences at intake, even though just the scale of this slide may make it look that way. The treatment groups really didn't differ in terms of suicide attempts. However, I was then very, very pleased afterwards to see actually that when we look at the 62% of the youth in this sample who had a history of suicide attempt before they got into the trial. So about 60% of our sample said, yes, I have a history of suicide attempt. About 40% said no. So we're dividing them here. So the youth who had no history of suicide attempt, regardless of what treatment they got, they stayed low. Those people may not be at risk, or they may not be at risk for suicidal behavior during this time period that we saw them. I think definitely we need to study that group more. And I'll talk a little bit more about that in a minute. But the really, really important take-home point here is that for the youth who had a history of suicide attempt, those who received standard of care psychotherapy actually had almost no change in their risk for suicidal behavior over follow-up. They continued to be at high risk, engage in suicidal behavior, and engage in more suicidal behavior over that 1 year follow-up. Whereas what you can see that the youth who received DBT, who had a history of suicide attempt, came down nearly to 0 by the end of the 1 year in terms of their number of suicide attempts and their risk for suicide attempts. So the take home here is that for those youth with bipolar disorder who have a history of suicide attempt, DBT uniquely targets that risk over 1 year. And we're also interested not only in does DBT work for decreasing suicide risk, but also how. Like, what is the mechanism whereby this is happening? And so our hypothesis was really about this change in emotion dysregulation, right? Because we know that treating mood is not enough to decrease suicide risk. But was it that improvement in emotion dysregulation with DBT that you saw earlier was actually what was underlying this improvement in suicidal behavior? And indeed, that's exactly what we found, that for those youth who were high on emotion dysregulation at intake, who had a history of suicide attempt, the means by which their suicide risk decreased was through improvements in emotion dysregulation with DBT. And so it's really exciting to be able to identify these behavioral mechanisms of treatment. And so this really gets us to this idea of clinical staging that I think you've heard about in various forms over the course of the morning. Really trying to think about which treatment is right for whom and when. And so lots of folks in the field have been thinking about this and doing really great work around this and trying to figure out what do we give to whom and when? Because the good news is we actually have several psychosocial treatments that we know work pretty well. And so what we've been talking about this morning is really down here in those stages 3 and 4, for those youth who have a history of suicide attempt. We want to think about which treatment is right for whom and when, and how do we determine that? What behavioral indices, genetic indices, neurobiological indices can we measure and identify are going to make somebody more likely to benefit from a treatment? But it's not just about the ability to benefit. We also have to think about burden. One of the biggest criticisms I think I get of this work is DBT is intensive. It is harder to learn than many other psychosocial treatments, and I can say that because I'm trained in a lot of them. It is more intensive. It requires a team approach. It's costly. And so that's part of the question is, for whom do we go to these more intensive treatments? And for whom can we start with less intensive treatments that will be equally efficacious? And so you heard this morning already about some exciting work in risk calculation, being able to predict what is going to happen for an individual, whether that's onset of bipolar disorder, which Rudolf had talked about. Danelle has done some great work in this area, but also we were curious about predicting risk for suicidal behavior. And so using that COBE data that I talked about earlier, those longitudinal data, we did some risk modeling to see if we could figure out, can we predict among youth with bipolar disorder who is going to make a suicide attempt over 1 year? Because while what I just talked about potentially may be life-saving treatment, we also need to be able to know for who is at risk. Because certainly we know from their history of suicidal behavior, but what about for the other percentage of youth who haven't yet engaged in that first suicidal behavior? The ability to predict that before it happens and then give them potentially life-saving treatment is so promising. And so that's some of where I get excited about going with this work, putting together risk prediction with treatment and making sure that we can match those. And so what we did was we developed this risk calculator among the youth in COBE. And what we found was that there were almost 250 suicide attempts among 106 individuals when we followed them over almost 13 years. And so we used this huge multivariate model. And what we found is that actually with just 10 variables that we all readily assess in everyday clinical practice, because that was really important to me in creating this risk calculator, that we weren't doing things that were going to be 20 years off from helping clinical care, but that actually we can learn something in our standard 50 minutes with a patient that we can use to predict what they need. And so we found that this predicted very accurately an AUC of 0.82 with pretty high sensitivity and specificity. So with just 10 variables, we can predict with great accuracy for a young person with bipolar disorder, how likely is it that they will engage in a suicide attempt over the year to come. And what you can see here is that we also found that this performed very well in our DBT sample. And so in addition to looking at rates of suicidal behavior over 1 year, we also looked at predicted risk score over the subsequent 1 year. And so what you can see here for those youth who received DBT, who had a history of suicide attempt, by the end of the 1 year treatment, their predicted risk, can you see my pointer? No, their predicted risk was incredibly low. So not only are we decreasing risk over that 1 year that we're studying them, but we're also decreasing predicted risk over the subsequent 1 year. Hopefully I'll be back in another year or two to talk about our longer term outcome data, because we also have data on that. So to find out to what extent was our risk calculator accurate in predicting that decreased risk. So Dr. Goldstein gave a little highlight of what's about to come. So I've been incredibly fortunate to work with this family at CYBD, even though Ben and I share the last name, we are not actually related, but you all do feel like family nonetheless. We've been working over the last several years on a dissemination and implementation study, because while these results are really promising, if we can't do this at places other than the University of Pittsburgh, it's really pointless. And so we need to make sure that we figure out ways to ensure we can train other people to do these interventions, do them with fidelity, and get the same outcomes. And so that's what we've been undertaking. And unfortunately, we know that most evidence-based treatments are not widely available. Whether you live in the US or Canada or the moon, it is really hard to get evidence-based psychosocial treatment, and even more so for less common disorders like bipolar disorder. And there are a host of reasons for that, including that it's more costly, or it can require more resources to train people. At least in the US, there's high turnover of mental health providers. And so we invest in training people and then they leave the field. And so these are a lot of problems that implementation science is trying to solve. And so our funding agencies have really been prioritizing studying implementation. And so we had this idea, let's try this at CYBD. You all also see youth with bipolar disorder who are at high risk. And so with so many of the fantastic folks in this room, we had undertaken this field trial that we called our DITTO study, Dissemination and Implementation Toronto. It's stuck, I don't know. But basically what we were doing was really trying to boil down, what did we do in that RCT? How do we train and supervise people in a way that is generalizable? What can we do to ensure that these programs are implementable at places other than the University of Pittsburgh? And how do we make sure that the therapists are doing the treatment at least good enough, and that the outcomes are similar? Because oftentimes what happens, we do these tightly controlled trials, but then when we try and do them elsewhere or in the community, many of the effects are diminished. And so how can we still get these same really positive outcomes on suicidal behavior when it's not University of Pittsburgh doing it? And so I'm just going to give you a little highlight. So these were some of the areas that we had looked at to try and study. So this was not just about looking at outcomes and can you all get the same outcomes that we got in our RCT, but rather let's study the processes for making sure that other people can do that. So we looked at data on barriers and facilitators. What gets in the way of people being able to implement these treatments? Satisfaction, both on the part of the clinicians and on the part of the clients and families, because it turns out that all of these are our consumers. Also, therapist knowledge and skills acquisition, which I am so incredibly pleased to share that all three of the therapists who were trained in this model have actually gotten their board of certification in DBT, which is not easy to do, and really was one of our primary outcomes in terms of therapist fidelity. And so this shows that the training that we did in the study was enough to show that these therapists are doing this treatment with fidelity. That can be hard to learn, and yet we're doing a good enough job to get them to where they need to be. They also happen to be great therapists, so we're going to need more implementation studies. And then, of course, patient outcomes, which we're very, very interested in as well. And so, in conclusion, and then I will get to your question. Among adolescents with bipolar disorder, when we compare DBT with standard of care psychotherapy, which are these other evidence-based treatments, we see a greater decrease in risk and fewer suicide attempts for those youth who have a history of suicidal behavior. The manner in which the mechanism whereby suicide attempts are decreasing appears to be through emotion dysregulation and improvements in emotion dysregulation, which are specifically targeted in addition to suicidal behavior in DBT, which is unique from some of the other evidence-based treatments for bipolar disorder. And so there are a whole host of next steps that I'm really excited about with these data. And if there are things you're excited about too, please come talk to me, because we have so much data and I will never have enough time or enough people working with me to analyze them all. And I get really excited about thinking about all that we can learn from these really fine-grained data. And so we currently are working with some folks in public health to analyze cost effectiveness, because on the one hand, DBT is an intensive treatment to learn and deliver. And on the other hand, there's reasons to believe it may be very cost effective in the long term in terms of decreasing emergency room visits, inpatient hospitalizations, and then of course potentially be life-saving, which we can't put any price on. We do have neuroimaging data both at baseline and mid-treatment. So ultimately we'll be able to, we're cleaning the data right now to be able to look at specifically some of the circuits that underlie emotion regulation to better understand not only are we seeing these changes at the behavioral level, but are we also seeing in them at the brain level. We also have results forthcoming from our dissemination study, some of which you got to see just a little highlight of today, but particularly looking at our outcomes. We have some other near-term risk indicators. I'm very interested in sleep as a near-term predictor of suicidal behavior. And so working with my colleagues in sleep medicine, we do have actigraphy data and sleep diary data on all of these youth as they're going through the treatment trial. And then, of course, ideally, we'd also be able to move towards prevention of that first suicidal behavior among youth at risk. So there's lots left to do, and I'm also excited about what we've been able to accomplish so far. It really is an incredible team effort. So many people in this room, folks online, all of my incredible collaborators, our funding agencies, and of course, without the participants and their families who put so much time and energy into our studies, we would not be able to accomplish any of this. And I thank you all for having me here today and for listening to our work.
So thank you so much, Tina. And I say this on behalf of everybody in the room and in the world. We're so glad that you do what you do. And we're hopeful that, really looking forward to what happens in the next years ahead. Dr. Uher.
Well, thanks so much. It's so nice and great to see new results from a political trial, something like this.
Thank you.
You mentioned how you got this specific with your family, and but you didn't mention the out of hours emergency contact that was typically part of DBT, but also was an issue in dissemination implementation. I wonder what's your view of it, and both whether you're doing it and how you feel it.
Yeah, absolutely. So I think the question was about coaching calls is what we call it in DBT, but it's essentially the out of session contact that we have in a standard DBT program with our patients and families. And so we did indeed use coaching as part of our model. And you can look at our open pilot and our small randomized pilot to learn more about how we did coaching. When I first started doing it, it was with a pager because that's how old I am. But now we actually, with the teens in particular, we do a lot of our coaching via text. The idea with skills coaching is that it's really to help these skills generalize. It is not a full therapy session, and I'm sorry for the therapists in the room who've heard me say this a million times. A coaching call is really like a 5 or 10 minute at most interaction with the patient that you're working with, sometimes with their family members, to help them identify what is their goal in the moment and what skills can they use, what skills have they already tried in order to move towards their goal. So in no way is it psychotherapy. That being said, many people shy away from doing DBT because they think, I don't want to be doing that at 3 o'clock in the morning. Like, I want to leave at 5 o'clock and be done with my job. What I can say is that our biggest problem with adolescents is not that they overuse coaching, but rather that they underuse coaching. I wish my patients would use coaching more than they do. In fact, so much so that we do a lot of scheduled calls early on. We have the data to be able to analyze, like, to what extent are coaching calls being used and how do they relate to outcome. But that being said, we also encourage the therapists to respect their own limits. And so you do not have to be on call 24/7 if you're doing DBT. That we work with any individual therapist to determine what is reasonable to them to be able to provide coaching outside of session. Sometimes it's between 9 and 5, sometimes between 7 and 10. Sometimes it's anytime you want to. And we educate our patients and families about when to use coaching, how to use coaching, and work with our therapists to be able to identify what's within their limits, recognizing that that can change over time. I personally do believe that it's a really critical component of DBT, and hopefully soon we'll have some data to show that in this population.
How, like, you know, in bipolar, we struggle with being consistent. So the problem is, as long as they are okay, they are in the average, they are fine, they can come to the therapy and that's it. But there are moments, I know that all of you know that, they stop everything, yes, and they just withdraw their medication, especially in the manic stages. So how were you able to control that part and manage to let them come and convince them, especially as teenagers?
That's a great question. So the question is really about like adherence and commitment to therapy. And so another thing I really like about DBT and drew me to it is that part of the initial stages of the treatment is building commitment to treatment, and not just commitment to this treatment today, but a commitment to we're going to do this for a year together. And here's why that's important. And there are going to be times where you're going to not want to come, where you're going to feel so good, you're going to think, this is stupid, I'm fine, I don't need this. And those are things that we'll talk about, that we forecast, and that we work on remembering why this is so important. And so we keep coming back to commitment. And so some of the data I didn't show today is actually that the youth in DBT got significantly more psychotherapy over the course of the year than the youth in standard of care psychotherapy. Now, granted, some of those are shorter term treatment models, but what we found in those youth who got standard of care psychotherapy, we do have an open clinic, so it's not necessarily time limited treatment. It's really like kind of clinically driven. But what we found was that there would be blips in treatment. A youth wasn't doing well, they came in more for psychotherapy, and then they were doing better and they stopped coming in. And then they started to not do well again, and then they got more psychotherapy, and then they continued to not come in. Interestingly, their mood outcomes are very similar. And so it may be that that's an effective approach. And one of the things that we found with DBT is that that consistent skills learning and generalization across mood states seems to be really important. And you're right, we struggle with it in DBT too. And some of it really is just about like forecasting it and working with it, recognizing it will happen. It happens for all of us. That motivation is something that waxes and wanes. Yeah. Thank you.
When I think about suicide, it's one of the components that we I wonder if you could track sensitivity and how that changed.
Yeah, so we do have data on impulsivity. I have not looked at it yet, so you're welcome to. I mean, we had in our grant, we had proposed, kind of a priority that the mechanism that we were most interested in was emotion dysregulation. But I absolutely agree with you, particularly in the unipolar depression literature, impulsivity hops out, and particularly in adolescents, as being strongly associated with suicidal behavior. So by no means am I implying that emotion regulation is the only mechanism. Suicidal behavior is incredibly complex and multifactorial. And so I think there's tons more work to be done to better understand what is changing and what's related to treatment, specific treatments, what's related to improvement more generally. But I think that's a very reasonable hypothesis to have. And it would not surprise me if that were, part of the mechanism underlying these outcomes.
I can do mine later.
Yeah, no, go for it. Last question.
We have time. Okay. So I really enjoyed the presentation of the moderation. I find when moderation is like tied into what you're trying to do with the treatment, that it's sort of especially compelling and has sort of automatic base validity. I had a question with the difficulty and emotional regulation scale. The graph was modeling, I think, as a median split. When you modeled the interaction, was that also a dichotomous variable, or was it continuous?
It was continuous.
It was continuous. Okay, I thought back to the slide, but I just wanted to check.
Yes.
Thanks.
Yes.
All right. Thank you, Tina.
Thank you all so much.